I'm Lauren Henke, and welcome back to another NRG Oncology podcast. I'm joined by my co-host, Dr. Stephen Chun. Today, we welcome our guests, who are Dr. Tom George, a gastrointestinal medical oncologist and director of the GI Oncology Program, as well as deputy director of the University of Florida Health Cancer Center, and Dr. Arvind Dasari, also a gastrointestinal medical oncologist and associate professor at the University of Texas MD Anderson Cancer Center.
For those of you who aren't familiar with the roles with NRG that Dr. George and Dr. Dasari have, Dr. George is the co-chair of the NRG Oncology Gastrointestinal Disease Committee, and Dr. Dasari is the principal investigator of NRG-GI008. Before we dive into the specifics about GI008 itself, which this podcast is about today, we should note that this is a trial run through NRG, SWOG, ECOG-ACRIN, and Alliance. And I want to ask first, what does it take to open a trial through multiple major cooperative groups, and how does NRG come to the decision which trials are best suited for this kind of approach?
That's a great question. So, we're in a situation these days where, collaboration is kind of the best way to get science done, the best way to get answers to questions most rapidly into the clinic. And so we were in a situation when Dr. Dasari and Dr. Liu brought forward a concept together, one through NRG and one through SWOG, to both test the idea of using circulating tumor DNA as a way to tailor therapies for patients with colon cancer. And there was a decision made along the way that it was best to bring the two together and answer that question as a team, as opposed to trying to compete with one another for resources, which include patients and other clinicians in practice. So to do that, we have to work through the systems, work through NRG and SWOG to bring this forward to all the other cooperative groups as well. One group needs to kind of run point and be kind of the coordinating center, if you will, and that was NRG's draw for this particular study. So Dr. Dasari serving as the PI and Dr. Liu as the co-PI representing SWOG worked together with the teams within NRG to bring in patient advocates to get their voice and their engagement early in the design of this concept, statisticians to make sure that the questions we were answering were going to be adequately answerable with the numbers of patients and the way we were designing the study, and then with a lot of other collaborating supporting cast members to help get the ideas designed, optimized, and then vetted through the other groups. So once the shell of the idea was developed, we then shopped it around. Dr. Dasari and Dr. Liu went on a roadshow. They went to the NCI task forces. They went and found other collaborators within ECOG, ACRIN, within the Alliance for Clinical Oncology Research, and were able to find champions in those groups that also were like-minded and wanted to see this come to fruition, get endorsements, and then ultimately it was vetted by the NCI and approved to move forward with protocol development. And that protocol development happened within the context of that team working together to get it going, and ultimately it activated. It's a bit of a tour de force. You have to kind of bring all the villagers together to make sure that it all works and that it's got something in it for everyone for it to be successful in the clinic. We were really fortunate also that after the fact, our colleagues north of the border in Canada saw what we were doing and said, "Hey, we want to participate as well." So they were able to come on board after we activated the study. So it's why it's also conamed CIRCULATE-NORTH AMERICA instead of the numerical number of GI008.
I think Circulate is well fitted to the study design itself. So as an intro into our discussion about GI008 or Circulate, I think it is important to define a key term here. A critical part of GI008 and its design is the use of circulating tumor DNA, or ctDNA as we like to call it. Is this the same kind of technology used in things like maternal fetal medicine, where doctors can tell the gender and detect genetic anomalies from a single maternal blood test early in pregnancy? Is that the type of technology we're talking about? Can you walk us through what happens to the blood so that circulating tumor DNA can be detected and used?
Absolutely. And the short answer is yes. I mean, circulating DNA in terms of clinical utility was used in the same setting that you mentioned, trying to detect fetal DNA in the maternal circulation and trying to find clinical applications for that. The idea is somewhat similar for circulating tumor DNA as well, in that there's a lot of circulating free DNA that comes from the normal cells in the body, largely from the bone marrow, where the turnover is the most rapid. And then there are small amounts of DNA released from cancer cells in patients with cancer. These typically tend to be short segments, about maybe 160 to 180 base pairs. We've known about ctDNA for a long time. It's just only recently that we've been able to develop the technology to reliably detect and isolate ctDNA. The neat thing is that the half-life of ctDNAs is just about 2 to 3 hours. So it's an incredibly kind of real-life, immediate picture of what's going on in the patient's body. And it's rapidly being used across the spectrum of oncology, right from early detection through monitoring for response in patients with metastatic disease on therapies. But by far, I think where we've realized kind of best use case scenario is the minimal residual states, that is, in patients who have undergone curative intent treatment. Say, for instance, a patient who has colon cancer has undergone surgery, so there's no visible disease either on scans or other clinical evaluations, but you do a ctDNA test and that comes back positive. What we know is that these patients are virtually destined to have a recurrence if nothing is done. As compared to patients who are ctDNA negative, their risk of recurrence is much lower. So an incredibly powerfully prognostic.
And so on that note, I would like to talk a little bit about the general management of colon cancer. These are cancers in the lower gastrointestinal tract, usually spanning from the cecum to the line of peritoneal reflection, defined often as being 12 to 15 centimeters from the anal verge. I imagine that probably most of the patients who might be considered for a trial like GI008 have undergone a colonoscopy, detected a tumor, and undergone surgery. And for this study, it includes from stage 2B disease, meaning it's broken through the wall of the colon, to stage 3 disease, meaning involving local regional lymph nodes. What is it that makes these tumors high risk, as they're called in this study? And what has been our general historic treatment of these cancers after surgery?
So maybe it would be worthwhile to take the example of stage 3 colon cancer and talk about how we're currently managing this and what the limitations are. And I think that'll give us a good idea of what the trial is trying to do. So adjuvant therapy at its most fundamental is a risk-benefit ratio, risk of side effects versus the benefit of reducing the chances of the cancer coming back in the future. The way we determine whether a patient needs chemotherapy or not is by trying to determine what the chances are of the patient's cancer coming back in the future. The best way we can do this currently is going by the TNM staging, like was just nicely outlined. So patients who have regional lymph node involvement would be the ones who have stage 3 colon cancer. Current guidelines suggest that these patients have a risk high enough that every patient with stage 3 colon cancer should get adjuvant chemotherapy. But what we know from historical data is that 40%, if not more, of these patients are cured by surgery alone and do not need adjuvant chemotherapy. But per current guidelines, we're treating them, giving them the toxicities of adjuvant therapy. On the flip side, the other 60% who are at risk of recurrence, unfortunately, with the current therapies, we're not curing everybody, even in those patients. It's probably probably a third or so of these patients. So if you were to take 10 patients with stage 3 colon cancer, we're treating everybody today, but in fact, we're only helping 2 or 3 of these patients. So what we really, really need is a better prognostic biomarker, wherein we can really identify the patients who are at the highest risk of recurrence and treat them with adjuvant chemotherapies, and then who are at the lower risk to maybe omit adjuvant chemotherapy. The second piece of this is that, as I just mentioned, the current adjuvant chemotherapies are not really that effective. So can we improve on that further as the second piece of the question?
So to expand on that just a bit, and as you also mentioned, the undertaking that chemotherapy is with regards to not just time, but also side effects that can linger. The choice of chemotherapy regimen is also an integral part of GI008. Can you give a general overview about the FOLFOX, CAPOX, and FOLFIRINOX regimens that are used in the trial?
Yeah, the chemotherapy that's used in the postoperative setting for patients with colon cancer is based on some very large randomized controlled trials that were conducted several years ago by the cooperative groups, by the NCI groups, and by NRG as well, that help to define what these regimens are, what these recipes are, but they generally entail 2 different medications. One is a medication that's called 5-FU or fluoropyrimidine. This is a drug that's been around since the 1960s. It's oldie but goodie. We know everything there is to know about it. It's been used in hundreds of thousands, if not millions of patients in the past. It's quite effective for patients with colorectal cancer. The tumor seems to be pretty sensitive to this medication. But it's a medication that requires being injected through the veins and typically requires being injected through the veins for several days or for several hours at a time. So can be somewhat inconvenient for patients where they need to be connected to a small machine or a device that can pump the chemotherapy into their veins for a day or two. And that requires them also having a central line, a special IV that allows them to receive the treatments at home even. So that medication led to us thinking about maybe there's an easier way to do it. Is there a way to have a pill instead? And that pill is basically functions in the body exactly the same as the intravenous chemotherapy does, but because it's a pill, it can be a whole lot more convenient. And that's capecitabine. So that's the CAPE part of CAPOX, and the 5-FU is the FOL part of FOLFOX, and those regimens. So we have the names kind of baked into the abbreviations. So that's one kind of ingredient in the recipe. The other ingredient is a medication called oxaliplatin, and this is a really potent chemotherapy medication that also requires intravenous injection, does not require a prolonged period of time to be receiving it, but it has its own special, unique side effects that go along with it. It's particularly problematic for patients who are diabetic or patients who have problems with previous nerve damage or strokes or things like that, because one of the side effects, one of the innocent bystanders that chemotherapy can affect are the nerves, and it can cause numbness and tingling. And for patients who are diabetic or have had strokes, they may already have that, or they may be predisposed to getting it. So these 2 medicines work really well together, and that's either FOLFOX or CAPOX. Those are the two medications that we use. And those are really the 2 primary recipes that are most effective for patients after surgery for colon cancer. The use of a third ingredient called irinotecan is a relatively newer medication that actually was derived from some trees and some plants that actually focus on the way DNA in cells needs to replicate. So if you go back to basic biology, the way DNA has to be separated when you go from one cell to 2 cells. It has to split down the middle. This chemical actually prevents that splitting from happening. So it stops cancer in its tracks, essentially. And that medication is really effective for patients with incurable metastatic or widespread colorectal cancer. But it too also has its own set of side effects because it inhibits DNA replication, it also affects other parts of the body that are dependent upon DNA replication. So it can affect the immune system, which needs to maintain a ready source of troops to fight off infections. It can affect the hair because that's constantly growing. It can affect the fingernails because they're constantly growing. So patients end up losing their hair and can be susceptible to infections with it. But the three of those medications combined is what we call the trifecta of, kind of the most potent combination of medications available for colorectal cancer. And that's the abbreviation for that is FOLFOXIRI or FOLFIRINOX.
So with all this in mind, when you set out to design GI008, I think we've already talked about how patients with a negative circulating tumor DNA test, we know from a prognostic standpoint that they are unlikely to recur. What sort of evidence do we have that a positive ctDNA test suggests the need for intensified chemotherapy versus perhaps run-of-the-mill FOLFOX chemotherapy?
A lot of the data that we have currently are from observational cohorts, large observation cohorts, and as you just mentioned, ctDNA negative patients do well, and their risk of recurrence is low. The patients who are ctDNA positive immediately after surgery, their risk is pretty high. So the question is then, what happens when we do adjuvant chemotherapy in these patients? Well, the answer is that it does clear ctDNA in as a proportion of patients. And so what that means is that you do ctDNA positive, you do adjuvant chemotherapy with FOLFOX or CAPOX, as we just discussed, and then check ctDNA again at the end of adjuvant therapy. We are clearing ctDNA in a proportion of these patients. Not everybody, but a proportion of these patients. But when you continue to monitor these patients over time, what we're starting to realize is that their ctDNA comes back again in a proportion of these patients, and they will eventually recur. So clearly, what we're doing right now is not enough. In fact, there are some studies that suggest that if you're ctDNA positive after surgery, you're probably helping maybe around 40 to 50% of the patients with the current standard of care therapy, and the rest will have a recurrence down the road. So how do we improve on this? And there have been really intriguing hints that irinotecan may be effective in this setting from other cohorts. For instance, stage 4 colon cancer patients who are the highest risk of recurrence being treated with irinotecan-based regimens where their risk of recurrence seemed lower. And also we have very robust data in patients with established stage 4 disease where we know for sure that this is much more effective in shrinking these tumors. So based on all these data, we really wanted to explore the role of irinotecan, not in everybody, but in these patients who are the highest risk of recurrence, and trying to do this therapy right off the bat and not after a period of time when there's maybe some establishment of this MRD status of micrometastatic disease and perhaps a chemo-refractory state that may come about by being exposed to FOLFOX.
So with all of this in mind and putting this all together, just to summarize, can you describe for us the study design and the major objectives of NRG-GI008?
Sure. So as we just discussed, this trial is for patients who have stage 2B, 2C, or stage 3 colon cancer. And after surgery, these patients would be evaluated for minimal residual disease using a Signatera assay, which is a tissue-informed assay. That is, we take a piece of the tumor tissue, sequence it, identify the most common variants, and then develop a pattern of kind of PCR test, and then we use that to test the plasma. And then based on the results of the Signatera, patients are put into one of two cohorts. Cohort A is patients who are ctDNA negative. And the question we're asking in this cohort is, can we safely delay adjuvant chemotherapy by doing serial surveillance for minimal residual disease? So patients would be randomized to immediate adjuvant chemotherapy according to current standard of care guidelines versus monitoring with ctDNA with Signatera every 3 months and offering them adjuvant therapy if and when they turn ctDNA positive. So the main question that this cohort is trying to answer is that whether kind of delayed adjuvant chemotherapy with surveillance for MRD is non-inferior to the current standard of care. In patients who are ctDNA positive immediately after surgery or those who turn ctDNA positive during surveillance, they go on to cohort B, where we are asking the question of can we improve on the current standard of care adjuvant chemotherapy? So patients would be randomized to K-FOX or FOLFOX, or the doublet, versus the triplet of FOLFIRINOX by the addition of irinotecan.
So if I understand correctly, this trial, GI008, is seeking to establish circulating tumor DNA as a predictive biomarker to guide adjuvant chemotherapy decisions for local regionally advanced colon cancer. Perhaps could you speak to us on the difference between a prognostic biomarker that you have both spoken about already and what a predictive biomarker is? And if this trial, GI008, is successful, will this be the first predictive biomarker we have in this setting?
Yeah, you nailed it. This study is exactly doing that. We've known for a long time, as Dr. Dasari previously described, that circulating tumor DNA is very prognostic. Patients who have a ctDNA positivity after surgery have disease left in their body somewhere that we just can't find. That's the source of the circulating tumor DNA. In patients who don't have circulating tumor DNA in their bodies, we don't think they have any cancer left. And that's more important than anything we see under the microscope at the time of surgery or any other clinical information that's available at the time of surgery. So this is a very powerful prognostic marker, meaning that it can help to separate a patient's situation into a good situation or a bad situation. That's really what the prognostic biomarker means. Doesn't tell us what we should do about it. Doesn't tell us if there's anything we can do about it. It just tells us what we're likely to see in the future, all things being equal. So what we're hoping to achieve with this study is to use that circulating tumor biomarker as a prognostic indicator to separate patients into a good group or a not so good group, and then also leverage the ctDNA to know if we were to intensify therapy for the group that's not likely to do well because we know they're destined to have cancer still left in their bodies. Can we improve on that? Can we do either what we're already doing or intensify it? And that's the whole point of that cohort B that was described. And that then becomes a predictive biomarker to be able to say that not only does it tell us that this patient's not likely to do well in the future from their cancer, but that if it goes away, if we can change that circulating tumor DNA, that biomarker from being positive to then negative with the treatments, that goes along with the treatment effect and is ultimately going to lead to their survival, improve their survival. So the predictive biomarker is related to doing something about it and knowing that it's going to predict the future.
Since activating GI008, accrual has maybe been a bit slower than what I think we could have hoped or maybe anticipated, especially with the different cooperative groups all together. What sort of barriers have there been to enrollment, and how can the NRG oncology community help improve enrollment on this trial?
Thank you for bringing that up. And one of the truly gratifying parts of doing this trial is really interacting with all the sites and investigators, getting feedback and incorporating that into amendments to make the trial more feasible and more attractive. As you mentioned, the enrollment was a little slow to begin with when we started the trial due to multiple reasons. And based on feedback, we changed some of the eligibility criteria so that it was broader. In terms of what kind of patients could be enrolled. The second key piece of advice that we got is, look, I mean, these are tests that are taking a while to report back because you need to collect tissue, collect blood, send it out to the central lab, and then it's processed, and those results then come back to the site. And patients are getting, as our providers are getting a little nervous and anxious about the delay because the dogma is that we want to get going with adjuvant therapy in a timely fashion. So based on this feedback, we actually amended the protocol to allow a dose of adjuvant chemotherapy to be done while waiting for these results to come back. And we also collaborated with CCTG, our Canadian friends, and the trial is open there as well. And I'm happy to report that actually in the last maybe 6 to 7 months, we're enrolling well and actually ahead of our planned monthly enrollment.
So when you have an eligible patient for GI008, can you give any tips to enrolling providers out there and clinical research teams about how to facilitate that accrual and how to lay this out for patients? I like some of the terms that you used, Dr. George, in describing this, but what is the best way to lay it out there?
Yeah, I can give an example of a situation we had just last week in clinic. Clinical care of these patients really starts for the most part with our gastroenterologists and our surgeons. And so we have really engaged our surgical colleagues to be in a position to discuss with the patient after they recover from their surgery that, based on the findings of their stage of the cancer under the microscope from the removal of the cancer, that they need to meet with the medical oncologist. They need to have a conversation about whether chemotherapy is right for them or not, and that they should also ask about whether a clinical trial is available. So we've kind of plugged that a little bit in the ears of our surgical colleagues. We haven't asked our surgical colleagues to get into the weeds or to talk details about it because it's something that we know a little bit better on the trial side in the medical oncology clinic, but we at least asked our surgeons to kind of tee it up a little bit and prepare the patient for at least that conversation and that offer. And that's good. It does two things. Number one, it allows the patients to read a little bit more about it. They get a little bit more comfortable with the idea of a clinical trial. They're not shell-shocked if that's thrown at them as a consideration when they meet with us in medical oncology for discussion of chemotherapy. But it also gives them a chance to reach out in advance if they want to learn more about what specifically are we talking about with a clinical trial, so they can be a little bit more empowered. That's been very valuable.
So this is obviously an incredibly important trial to establish true, what I would call patient-tailored treatments for high-risk colon cancer. We see the term patient-tailored a lot in medicine, almost to the point that it's a cliche, but I really want to emphasize here that it's actually pretty rare that we have trials or interventions that are truly tailored, say, to a patient's circulating tumor DNA. And I want to just thank you for joining us today, both Dr. Dasari and Dr. George. The NRG Oncology Group is supported by grant funding from the National Cancer Institutes of the National Institutes of Health, and content of this podcast does not necessarily represent the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.